Hello, everyone. Welcome to our next edition of the AAP section of Neonatal Perinatal Medicine Journal Club webinar. This is our sixth year of doing it, and it's a pleasure today to have Dr. Barbara Schmidt and Dr. Wally Carlo talk to us about caffeine. I was talking to Dr. Schmidt just a little beforehand. She has presented us with us long time before with Dr. Joe, and was one of the most well-received sessions. So I'm very excited for today's session of having both these prominent experts joining us. And Dr. Schmidt's joining us all the way from Canada, and Dr. Carlo is being a really good grandparent and trying to make sure his kids are around, and he's joining us while his wife drives around so that he can make time for his family as well as make sure us as trainees get all the attention we need. With that, I'll have Maddie introduce us, Dr. Barbara Schmidt.
Okay, thank you for that. It's my pleasure today to introduce Dr. Barbara Schmidt. She's a professor in the Department of Health Research Methods, Evidence, and Impact at McMaster University, and a professor emerita at the University of Pennsylvania in Philadelphia. Throughout her illustrious career, she's led several large international neonatal randomized trials with clinically important long-term outcomes, such as the trial of indomethacin prophylaxis in preterms or TIP, caffeine for apnea of prematurity or CAP trial, and the Canadian oxygen trial or COT. She has also mentored countless talented neonatal trainees in evidence-based neonatal practice and clinical research. Dr. Schmidt has received the highest honors in her specialty, including the Douglas K. Richardson Award from the Society for Pediatric Research, the Virginia Apgar Award from the American Academy of Pediatrics, and the Arvo Jippo Medal from the Finnish Pediatric Research Foundation. She's also a member of the Order of Canada. Welcome, Dr. Schmidt.
Thank you very much for having me, Matt.
And it is my pleasure to introduce Dr. Carlo, who's the chair of neonatology and professor of pediatrics at UAB. His research is focused on neonatal and childhood research performed in developing countries primarily, and a lot of in the US, and one of the trials we'll see here today. His main research interest is in clinical research, including the design, implementation, and reporting of neonatal research, and he has designed several important trials such as the First Breath trial, the Brain Hit trial, the Support trial, and the MoCHA trial. He leads the UAB sites of NIH-funded networks, including the Global Network for Women and Children's Health Research, as well as the Neonatal Research Network. He is also an inventor of the multiple hats he wears and has developed innovative devices. So the jet frequency ventilator is his innovation, a flow interrupter to perform pulmonary function tests, which we use now in a lot of our research setting, as well as a low-cost oxygen air blender used in low-resource settings. He's also a pioneer in neonatal evidence-based medicine and has mentored many trainees who went on to be leaders and successful researchers. And it's a pleasure for us to learn from him today. And he's also recipient of numerous research awards, including the Virginia Apgar Award. Thank you so much for joining us, Dr. Carlo, and making time for us.
Thank you very much, Vera, for the opportunity to be here today.
With that, we'll have Dr. Sreenivasan take over. Just some housekeeping stuff. As always, if audience have any questions, feel free to put it in the chat. At the end of the session, we'll go through each and every questions that you have.
Good afternoon, everyone. Thank you so much for the opportunity and for the platform for discussion and enriched learning for everyone together. And thank you so much for Dr. Schmidt and Dr. Carlo for being here while we are reviewing the article together. So today we are going to be discussing about the MoCHA trial, which Dr. Carlo PI'd, which is the extended caffeine for apnea and moderately preterm infants. So this is just an overview about what are the topics that we are going to be touching upon as we are discussing through the article. So just to start off with a little bit of background, so caffeine is a common medication widely used now in preterm infants. It is used for apnea of prematurity, and prior studies have shown it to be almost equally effective to theophylline, if not more, decreased side effects than theophylline, and easy to administer. And the benefits are decreasing apnea, decreasing intermittent hypoxemia, and also enabling with extubation success. It is also shown to reduce BPD, PDA, and also improve survival without major disability. As with any medication, we want to also know what are the side effects. So for the short-term side effects, it's been associated with tachycardia, feeding intolerance, irritability, and diuresis. And with the long-term follow-up, there has been no significant adverse neurodevelopmental effects. On the other side, it has actually shown some positive evidence with improved outcomes. Before we jump to the well-renowned CAP trial, there has been multiple studies investigating the role of caffeine in our neonatal population, and it starts as early as 1970s. Of these four, these are the four studies that I was able to find before the CAP trial, and as we can see, and the conclusion was basically it was more safer than theophylline and definitely effective than placebo and easy to administer. And it also had good neurodevelopmental outcomes as well. And I'm glad to have Dr. Schmidt here, who ran the CAP trial. It's the large randomized control trial in very preterm infants, which showed that caffeine is associated with decreased BPD and severe retinopathy of prematurity. And it also decreased the cerebral palsy at 18 months. It improved motor functions into childhood. And the CAP trial made it possible to establish caffeine as standard of care across all the neonatal ICUs. So after the CAP trial, the recent findings, especially concentrating on the late preterm population. One such trial was the Oliphant et al. Trial. It was also a randomized control trial conducted in 2023. And their study population gestational age was 34 weeks, so 36 and 6. 132 infants fit into the study population, and they tried to find which dosage was appropriate and more effective in reducing the intermittent hypoxemia in moderately preterm infants and late preterm infants. And there is another slide towards the end of the presentation where it shows which dose was appropriate, but it did show that caffeine at appropriate dose improved the saturation stability, and it was well tolerated with no effect on growth or sleep, and did not have any sleep disturbances. So far with the other trials, the knowledge gap that has been existing is that most of the data exists in the very preterm population, and the moderate and late preterm infants do form a majority of the preterm population as well, and they are underrepresented. And so far, the unclear information is the optimal dose and duration of caffeine in the especially moderate and late preterm infants, long-term neurodevelopmental outcomes with caffeine administration, and the best timing of initiation. So this is just to put into perspective about the timeline of the caffeine studies. So as we just saw, the study started as early as 1970s, and it's slowly graduated to now at 2025 running the MoCHA trial. And Dr. Carlo, I would love to hear your perspective into the trials and the caffeine.
Yeah, so a lot of evidence that caffeine is beneficial early. So in the extremely preterm babies in the first weeks of life, you saw the data from the study, the CAP trial by Dr. Schmidt, and the benefits, long-term benefits included. So the question that we had was, how about continuing caffeine or extended caffeine? Will it have benefits on these patients?
Okay. Thank you, Dr. Carlo. So as Dr. Carlo just explained, so why the MoCHA trial? Because as we just discussed, the moderate and late preterm infants constitute a significant proportion of the premature infants or preterm infants. And they also have associated intermittent hypoxemia and apnea. And infants having intermittent hypoxemia and apnea have been linked to increased neurodevelopmental risk. So even with the prior evidences, it is promising to use caffeine, but there is no, especially no randomized control trial showing effectiveness of caffeine in this population subset. So let's dive into the article as such. So in any randomized control trial, we want to format our hypothesis into a PICO question, which is population. We are addressing the trial to the intervention that we are using, and what are we comparing the intervention to, the outcome and the time. So the PICO question for the MoCHA trial is in moderately preterm infants with the gestational age of 29 to 33 weeks and 6 days at birth. Does caffeine therapy compared to placebo reduce the time to hospital discharge during the NICU stay?
Dr. Carlo, I hope you could give us some insight here as to why you chose reduction in time to hospital discharge as your primary outcome amongst all of the possibilities.
So we wanted to look at something important. Let's say caffeine has been used around the time of discharge and continued till 4 weeks after discharge. So the question was, okay, so can we start caffeine early when the patients are about ready to go home, but still coming off caffeine? And can the use of caffeine, extended caffeine, reduce lengths of stay from randomization to discharge? So the primary outcome was from randomization to discharge. These babies are healthier, but sometimes when one stops caffeine, they start having apnea again.
Thank you.
Yeah, and for that, physicians use it. So they, instead of stopping caffeine in the hospital, as the paper documents, maybe 30–40% of the physicians in many countries, including the US and Canada, use caffeine after discharge on this baby. So they continue caffeine instead of stopping it around the time of discharge.
Got it. Okay. So the study's design of the trial was, it was a randomized controlled trial, double-blinded study done over a period of 3 years from February 2019 to 2022. And it was a multi-center study, including around 29 hospitals, which was institutions which was recognized by NICHD. And the IRB was approved at each each institution. Written informed consent was obtained and the reporting guidelines were followed. Through the presentation, I just have inserted my thoughts into every slide. So, and I would love to hear your thoughts as well. So for the study design, I found it was good that it's a double-blinded study, that it decreases biases, and it's definitely a long period study to see any differences. Multi-center study is a good thing because it actually includes diverse population and it increases the applicability of the study across population as well. The inclusion criteria was any infant born at 29 weeks to 33 weeks and 6 days gestation at birth, and who at the time of randomization was 33 weeks to 35 weeks and 6 days, receiving caffeine but with a plan of discontinuing treatment, and receiving oral and or tube feedings at 120 ml per kilogram per day or more, and having the ability to start either caffeine or the placebo after randomization within 72 hours if the caffeine was already discontinued on the infants. So I felt that the inclusion criteria was very clear, and since the feeding always is a barrier to discharge, including the feeding and having put that into an inclusion criteria was really good as it also changes the primary outcome. Exclusion criteria, any infant receiving the respiratory therapy, being discharged on apnea monitor or parents requesting apnea monitor, any infant with congenital heart disease other than ASD, VSD, or PDA, neuromuscular condition affecting respiration and any congenital malformation, and infants who were planning to be transferred to non-research institute or the institution who were not involved in the trial.
So,
yeah.
Dr. Carlo, question for you. Does excluding babies with respiratory therapy, considering we know it's caffeine's benefit on the respiratory system, was an important part in your exclusion criteria?
Well, the issue was, for example, we definitely wanted to exclude patients who were receiving CPAP because that would delay discharge, and our primary outcome was time to discharge from randomization. The issue then on the oxygen, it depends. In some units, it's common to go home on in oxygen, and in other units, they try to get them off oxygen. So we didn't want those barriers to interfere with the primary outcome.
Got it.
Thank you.
And my other question was, I didn't quite understand why infants on apnea monitor or parents requiring apnea monitor were excluded.
That's a very good point. Why exclude patients on who are going to go on a monitor? And in fact, initially, we thought the baby should go home on a monitor, but we thought that would blind the parents possibly. So we did not want to have, and we trying to make this generalizable. We wanted to see if it would work without monitors. Then the issue is, should monitor be an exclusion? And that was an important issue to discuss and to agree. And the group agreed that it was better to not have monitors. You know, not many physicians send babies routinely on monitors, and not many parents wanted. So it was not a major exclusion criteria, but yes, patients were excluded for that.
Okay, got it. Thank you, Dr. Carlo. So the outcomes they looked at is the primary outcome is the days to discharge after randomization, and the secondary outcomes were days to physiological maturity, which was defined as apnea-free for 5 consecutive days, receiving full oral feeds, and out of incubator for at least 48 hours. The secondary outcome also included post-menstrual age at the time of discharge, and all-cause hospital readmissions, and all-cause sick and emergency department visits, safety outcomes, and death. My other question was, since there are 29 institutions involved, the criteria for discharge is highly variable. Like some institution may hold the infant for apnea or bradycardia for 5 days apnea free, and for other institution maybe 7 days. So throughout the institution, was it standardized, the criteria for discharge?
What we did is standardized criteria for physiologic maturity. So that was independent of discharge, because as you mentioned, different units have different practices. So to standardize a secondary outcome when we could not necessarily standardize the primary outcome, because the criteria for discharge varies. Sometimes there are social issues also, not just medical. So we thought it would be important to get a secondary outcome that was standardized, such as physiologic maturity.
Got it.
But I think it's important to say that, I mean, that variability can potentially be a problem, but only if there is biased assessment. So the blinding prevented biased treatment or biased discharge. And the variability you tried to deal with, which was done in this case again as well, by stratifying by center. So whatever is idiosyncratic about the discharge policy at a particular center would be applied equally to the 2 comparison groups. So variability is just a fact of life in medicine, right? But I think all precautions were in place to make sure that it didn't bias the results.
Got it. Thank you, Dr. Schmidt. So going on to intervention, infants were randomized into either receiving caffeine as caffeine citrate, which was 10 milligram per kilogram per dose, which contained 5 milligram per kilogram caffeine base, or an equal volume of placebo daily. It was continued throughout the hospital stay and for 28 days after discharge. So in the hospitals, the dosages were weight adjusted weekly, and the apnea monitoring was done by neonatologists with reliance on the clinical monitoring and apnea monitor. And infants receiving study drug, if they remained inpatient after 44 weeks post-menstrual age, was excluded, had the study drug discontinued. So my other point of discussion was the apnea events are heavily dependent on the proper documentation, and sometimes it depends on these nurses, bedside nurses, who document it appropriately. So was there clear reevaluation to confirm whether these events were actually truly apneic events before confirming them to be continuing to have the events?
Yes, so you correctly pointed an issue is how to monitor apnea, and the practice was diverse between the institutions, how much emphasis they put. That's why we had physiologic maturity criteria specifically determined, predetermined. And then as Dr. Schmidt mentioned, because the randomization was by center, we minimized problems because it was a placebo trial.
Got it. Okay. And for infants who were discharged on caffeine at home, the parents were supplied with 28 number of vials based on infant's weight, with parents to record information of administration, and home apnea monitoring. Obviously, it was one of our exclusion criteria for better study, and the follow-up was done frequently after discharge. The only thing was, the only thing I had a question about, as especially in premature infants, the caffeine metabolism changes with age, and since we don't have a caffeine level and we are not weight adjusting them even after discharge, would it be possible that the caffeine level was not in the therapeutic range after discharge?
It is possible, yeah. And in fact, around the time of discharge, it's been documented that the optimal level is a little bit higher, probably 14 milligrams per kilo or so. We thought it would be better to stick to the common practice of 10 milligrams per kilo, and not use higher doses. Higher doses have been used and have been shown to be effective, but there's limited data on safety. So we thought it would be better to stick to the FDA recommendation and the common clinical practice of 10 milligrams per kilo.
Got it.
Dr. Schmidt, you want to comment on, because 5 to 10 milligrams is very well established from your CAP trial. What's the latest understanding, on your opinion, on the higher doses of caffeine in these kind of late discharge population?
So it is, of course, true. But first of all, right after birth, and for the first few weeks, the plasma elimination half-life is very long. But it is true that as the child matures, that it becomes a bit shorter. There are even sort of theoretical algorithm out there that has been published about how much one would have to adjust on a biweekly schedule to account for that shortening of the plasma elimination half-life. Some years ago, when this paper is also already a few years ago, I actually calculated that in the CAP trial, with our opportunity to let the clinicians go up to 10 milligrams per kilo and day of caffeine citrate, we actually covered those necessary increases. So they wouldn't have led to higher doses for the typical duration in hospital. Now, beyond discharge and going up to maybe 40 plus weeks post-menstrual age, you know, I think none of us really knows what happens to the metabolism then. But remember that the primary outcome had nothing to do with what was done in terms of caffeine after discharge. You could even, you know, some people actually wean caffeine, which I've never understood quite why they do that, but some people do that. But you know, the primary outcome was at hospital discharge. And up to that time, and you know, we know how long it took to discharge, the 10 per kilo per day, I believe, were totally adequate, and we see it in the data that you'll show us shortly. What happened after discharge, and you know, whether it was a little bit too little for what? It wasn't really influencing critical outcomes any longer. It was just basically a way to cover any eventuality that the child might still have a breakthrough apnea. Does that answer your question? And I have made no secret of it. And wherever I talk or whenever I write about this topic, I've made no, I stress that I'm very concerned about people using much higher doses than both for loading and for maintenance. Because yes, in the short term, you may get a little bit more bang for the buck, but nobody, there's no data at this point has shown us that this is safe for the long-term development. And the reasons why we did the CAP trial were on a sound body of evidence that it can do harm. It's just that the benefits in the way we used it in the CAP trial and the way that most people use it now outweigh the possible harm. But if you just keep pushing, and especially give even higher doses to kids who don't even really need it as a respiratory stimulant, you will still run the risk of harm. That literature and that evidence hasn't just simply disappeared with the CAP trial. It's just that as a respiratory stimulant in kids with poor respiratory control, it does more good than harm.
Yeah. Thank you so much for your insight, Dr. Schmidt. Sreenivasan, you can continue.
Okay, thank you, Dr. Schmidt. So this is just a flowchart of the patients who were screened and who became eligible and who were randomized. To start off with, 6,635 infants were screened for the study, of whom 296,693 infants were excluded and 3,942 infants were eligible, and of which 3,115 infants were excluded. And I will show down a total of 827 infants were randomized, either receiving placebo or caffeine. So the question, so the good things were, like, it's a detailed enlistment of the study population, including the criteria for exclusion and majority. The only question I had was the inclusion criteria, and the infants who met these inclusion criteria were still excluded. And I was just wanting to understand what was the specific reason for their exclusion.
Okay. So we have to be careful that we excluded patients that would not be like typical of the patients we wanted to include. So that's why there were several exclusion criteria.
Got it, Dr. Carlo. So 827 infants were randomized, and of whom 416 infants received extended caffeine, and 411 infants received placebo. And they were followed up post-discharge, and at the end, 416 infants were included in the primary analysis from the caffeine group, and 411 were included in the primary analysis from the placebo group. I was just wanting to understand, of the 416 in the caffeine group, 25 of them did not receive intervention as randomized, and similarly in the placebo group as well. Just wanted to understand what was the major barriers in like them not receiving the randomization.
Wally, you're on mute.
Yes. Sorry, what was the question? I missed the
Sorry,
question.
the infants who didn't receive randomization as they were planned to, I was just trying to understand the barrier.
Yes, so sometimes, let's say we enroll the patient, randomize them, but they don't get the treatment. That would be like typical. They don't get the treatment because they are born during the weekend. It's difficult to get the medication ready. So there are sometimes some post-randomization exclusion, you know. They were minimal, as you see.
Okay, Dr. Carlo. And so this is just enlisting how many infants received the caffeine and the placebo. So if we account for all the attrition, that 345 infants with caffeine was continued to follow up versus 351 in the placebo group. The only question I had was in the power analysis in the study, it was shown that 439 infants were required per group to meet the power 80%, but if we calculate, the power was not met for the study.
That's correct. We did not reach, in fact, the hope was even more patients, and the study had to be terminated early because of futility. So we did not meet the power requirements. Yeah.
So just Gayathri, so we're clear. This is not an underpowered study. The study was monitored with interim analyses by an external monitoring committee, and they determined along the way, based on what was actually in the protocol and decided before the study started, that they had a certain threshold for when futility would be declared. In other words, when it was so unlikely that the study showed any benefit that it was futile to continue. So this is therefore irrelevant in this case, that they were not supposed to reach their target sample size because of this issue, because of this interim analysis. I think it was at 75% followed to 8 weeks, right?
I understand, Dr. Smith. I think that makes a better explanation. That it's good to understand right now. Thank you. So coming to demographics of maternal demographics, the two groups were similar, the caffeine and the placebo group. So initially, when I was putting the slide together, I was wondering about, obviously, with every study, the p-value. So I think like with randomized control trial, I came to learn that if the infants are appropriately randomized, so the two groups are pretty much similar, and the p-value is not going to be of use in a randomized clinical trial. So just little overview on the pros and cons of p-value is that the p-value helps to provide a quantitative measure of differences, especially when it comes to smaller studies, and can flag potential confounders early in the analysis. And most of the time, most of the studies and the reviewers, they expect it for transparency. But the cons of p-value are, as I just talked about, randomization already balances out the group. So the p-value testing in that scenario can be misleading. And small trials may miss important imbalances due to power. And sometimes it also encourages p-hacking mindset, which is basically focusing on the p-value rather than the effect sizes and confidence intervals.
So that's all true what you put up there, but there's a little bit of a mixing up going on between the use of p-values in this typical table 1, the baseline characteristics comparison or comparison and randomization, vis-a-vis using p-values for analyses of outcomes, right? And much of what you say, especially under cons is not all of it, but certainly that they can show statistically significant but clinically irrelevant differences. So that's all true, and that's why we've moved pretty much away from p-values for outcomes to confidence intervals around whatever the measure is, relative risk or odds ratio. But the baseline, because you started the conversation about the table 1, right? The baseline and the status at randomization. It is really, the first thing to say is, in this case, you had over 800 patients, and that's a large trial by most people's standards, certainly in our specialty. And so the chance that you get very comparable results in the two groups is very high. But if you have a small trial, it doesn't necessarily, randomization doesn't necessarily guarantee comparability. But it still makes no sense to put p-values in that table 1, because if randomization was done correctly, which we assume, and when it's getting to this stage of being published in a peer-reviewed journal, then any statistical difference would have arisen by chance. That's just the context of, where that data comes from. So it makes no sense. These are meaningless p-values for that baseline comparison. Outcomes is a very different kettle of fish.
Got it.
Right?
Correct. And, as you all know, now most baseline characteristics tables, most journals don't want p-value. So if you put p-value, they will recommend taking it out. And if there's any difference, you can do a note under the table and mention the difference. But with a large sample size like this, you would not expect important differences.
Got it. Coming to the infant characteristics, so the only question I had, kind of like a discussion point, I just was curious to understand when during the what course of the hospitalization that these infants received, like, let's say, intubation, chest compression, epinephrine, or oxygen. I would pretty much assume it was early in the course, because and if it's in the middle, then it can also represent severity of the infants.
Yes, those were at any time during the hospitalization, they have had those treatments.
Got it.
So, Wally, I actually have a question for you at this point, and I made a one-sentence reference to this. This is the status at, 34 plus weeks post-menstrual age. And I was just curious, I was missing one piece of information in this table, and I wondered whether you had thought about it and then decided not to put it in. I think it would have been helpful for us readers to see at the time of randomization how many kids in each group had actually reached the 3 different types of skills that made up your physiological maturity. How many kids were already in a crib? How many kids were already on full feeds? How many kids had already gone through 5 days without apnea? Do you see what I'm getting at?
Yes,
I think
definitely.
that would have that was the only thing I was really missing. I was surprised that it wasn't there, because if you had an imbalance there, that would have been, chances are you didn't, but it would have been interesting to see.
So that's a good point. We did not report that because as a large sample size, they should be balanced. They were balanced. But importantly, the primary outcome was from randomization to discharge, and they had to meet criteria, local criteria, to come off the caffeine.
Okay.
The other question I had was, it would have been helpful to know the preterm complications of these infants, because I feel like sometimes they can also have an influence on their physiological maturity as well.
So we mentioned some of those things, like respiratory support. Yes. We did not go into all the details of baseline other characteristics before randomization.
So for statistical analysis, we discussed about the power and we stopped at it with the study because of its futility was not supposed to reach the power and it was internally valid. And we used the survival analysis for the assessment and we just ran over the p-value as well. So just a little bit about survival analysis and why the survival analysis was chosen for the MoCHA trial. So survival analysis is a statistical method for time to event data. So in the MoCHA trial, it was time to hospital discharge. And since infants have been discharged at different times, some of the infants might, when the study ends, we can still use their data even if they have not met that endpoint. And the usual representation of a survival analysis is the Kaplan-Meier curves, which on the x-axis is the days since birth or the number of days in the NICU, and the y-axis is the proportion remaining hospitalized or in going forward, I'll also show you the graph from the study, which they use survival probability. So at day 0, everyone starts with 100% on the y-axis. So the graph shows us if there is any difference between the two groups. For example, here the blue is the caffeine and the yellow is the placebo. So if there is any difference between the two groups, then we see the difference in the curves as well. So when the study is definitely internally valid, I just ran it through the JAMA tool just to for my understanding of how a randomized control trial works and what all things to look out for a randomized control trial as well. Going to results. So the primary outcome, as we just talked about, is the number of days of hospitalization. And there was no difference between the extended caffeine group and the placebo group. And but infants on caffeine became apnea-free sooner than infants on placebo. And we talked about the inclusion criteria of the infants who were on oral feeds or at least oral or tube feedings of at least 120 ml per kilogram per day. But I just had a question, like, would it have been better, and I think Dr. Schmidt brought it up, like, would it have been better in a subgroup analysis if we chose infants whose primary driver for discharge was the apnea or bradycardia events, that we standardized like infants receiving complete oral feedings as well?
So yeah, I think these are issues that are important. Let's say, should we only should have done the study on patients that were already on full feedings?
Mm-hmm.
And the reason was that these babies were not ready for discharge at least for apnea. Mm-hmm. And some babies get to full feedings and then they need back the OG tube. So we thought to make it more generalizable, it would be better to take a more complete population. The other issue that was reported in the largest cohort study on the subject was a study by Eric Eichenwald, and in which multi-center study in which they showed that being on not being on full feedings also was associated with not being apnea free. So the idea was maybe these babies have something in common because they're not mature enough and they need to get solve the problem of apnea and solve the problem of PO feeding at the same time or near the same time. So we thought, okay, maybe giving caffeine will accelerate the process of getting them to full feedings also.
Got it. Thank you, Dr. Carlo. So the other thing the study showed was that the infants on caffeine initially had a lesser weight gain of 3 grams per kilogram per day than compared to the placebo, but then the growth trajectory was not altered. So it was transient and short-lived. The only other question I had, in different outcomes of assessment, the denominator was different. So I was just wondering why the change when it came to different assessments.
sorry, which differences in the denominator?
So like, for example, in the extended caffeine group, like for, let's say, anti-reflux medication, or the denominator was 414. I know it's a small number, but I was trying to understand because the total number was 416.
Yes, some babies are discharged, for example. So we may not have all the data
Okay.
that were discharged earlier. Yeah.
Sounds good, Dr. Carlo. And the other question I had, because in the inclusion criteria, it was few infants were missed during the randomization or did not receive the randomized therapy, but were included in the analysis.
Yeah, so that would be the correct way to do a study in general. It's intention to treat, not per protocol analysis, because only few patients did not follow the protocol. Then we reported only intention to treat as the preferred way to report studies like this.
But just Gayathri, so people who look at this slide don't take away the wrong message.
Yeah.
Everybody in this analysis was randomized. So if you want to, they all received, quote unquote, the randomization. What not everybody received was the intervention to which they were randomized. So this does not include any of the babies who were not ever randomized. Okay. And then, as Dr. Carlo said, the correct analysis is, even if they didn't get the intervention, and it's a relatively small number, as we saw before, to include them in the analysis. Because there could be all sorts of reasons. Again, if you just pick the ones that performed best, that did everything they were supposed to be doing or something, you could actually reintroduce bias that you were trying to reduce by randomizing. So you would undoing some of the good that randomization was supposed to achieve if you then pick and choose who you're actually including in the analysis.
Makes sense. Thank you, Dr. Schmidt. I understand. And infants on the caffeine group was found to be having a little more tachycardia than compared to the placebo group. This is just my thought that maybe having an infant's hematocrit would also had weighed in a little bit more, because the hematocrit can also be, low hematocrit can also be associated with tachycardia.
Yeah, but you have a large sample size, so that should even out. The difference, obviously, was the caffeine intervention.
And it's a very well-known side effect, and it's dose-dependent. So again, good sign that the dose was probably not too low. But the tachycardia, and over 200 is pretty good going. It's basically doubled, no? More than doubled in the caffeine group.
And the other point I just wanted to understand was, I think because of physiological, I know we define physiological maturity, but then for a 29-weeker, getting to the physiological maturity is different from a 33-weeker getting to that point. So maybe would it have helped if we stratified or had data based on the gestational ages?
Well, that would, in a way, take care of itself by randomizing patients. And we're randomizing patients between 33 and 35 weeks. So some babies may be randomized earlier or later, but it's all by site and by randomization, so that evens out.
Got it. Okay.
And didn't you adjust in your median regression for gestational age?
Yes, we adjusted. Yeah,
I would have to go back to the paper, but I think you did.
Yeah, the results are adjusted results. Yeah.
This is the Kaplan-Meier curves that we just talked about before for the survival analysis. So it reflects the results. On the left is basically the days to discharge. And as we can see, there is no difference between the extended caffeine group and the placebo group. But on the right side is the graph for how many days it took to become apnea-free after caffeine or placebo. And as we can see, the caffeine group attained apnea and bradycardia-free compared to placebo sooner. And the list of the adverse events, I was glad to know that there was totally low infection rates across the hospitals, just a little observation. And there was no increase in severe complications, no sustained impact on growth, and consistent safety across all subgroups. And as we just talked about, there were higher tachycardia rates in the caffeine group and transient reduced weight gain, but no long-term development data yet based on these based on these findings. And post-discharge outcomes, there was no change in all-cause readmissions, and it was a comparable overall study, and it was consistent across all subgroups with reassuring follow-up. I think this is probably a topic for another study. It's just that for a longer follow-up duration to understand the neurodevelopmental aspects of prolonged caffeine therapy, and because of that, the post-discharge events can be limited or captured limited. Yes, Dr. Carlo?
Yes, so yeah, we have to decide, do we spend the money doing a large follow-up trial, follow-up study? And, it's expensive to follow 800 patients. So we thought follow-up to 8 weeks should be okay not for neurodevelopment, obviously, but for the acute issues related to apnea and bradycardia, maybe rehospitalizations, visits. So we thought 8 weeks should be sufficient to make those assessments.
Got it. So this is just conclusion from the study so far, that the number of days of hospitalization from randomization to discharge did not differ between the two groups. There was no difference in number of days to physiological maturity. Infants in the caffeine group were apnea-free sooner than the one in the placebo group, with an adjusted relative risk of 0.22. And the mean weight gain from randomization until discharge was lower in caffeine group. It was statistically significant, but it's not clinically significant because the rate was low and it did not alter the growth trajectory. And there was no statistically significant difference in adverse events between the two groups. The mean percentage of doses administered after discharge was 79.5% in caffeine group and 87.6% in the placebo group, which was statistically significant. So this is basically a synopsis of what we just read so far, but I think there was a mention that probably the dosage of caffeine was not appropriate for the treatment, and I think that's where the reference was made to the Oliphant trial, where they found that 20 milligram per kilogram per day was effective in decreasing the hypoxemic events in the late preterm infants. And as we all discussed, the strengths are large sample size, multi-center design, assessment of important clinical outcomes, and double-blinded study. And it's pretty much advanced to prior studies which were not powered to assess for clinical outcomes. And it provides strong evidence to compare the clinical outcomes of infants discharged home receiving caffeine with those receiving placebo. The limitations of the study were the treating physicians were allowed to individualize management of possible apneic events, and it was largely dependent on the clinical documentation for assessment of apnea-free duration, and to which Dr. Carlo explained that we kind of set the physiological maturity across and standardized it across the institutions, and also randomization by itself will try to reduce these effects. And lower percentage of doses planned were given in the caffeine group. analysis of secondary outcomes were only used for generating hypothesis and did not include adjustments for multiple comparison and non-inclusion of less than 29 weeks. But I think the CAP trial and Dr. Schmidt's trial were pretty effective in the very premature infants. So this, sorry.
Yeah, as you noted, many of the weaknesses that you mentioned are overcome by being a randomized control, placebo-controlled trial. So, so for example, for the primary outcome, that's the main issue. So it was a robust evidence for the primary outcome. For the secondary outcomes, there are some limitations, but obviously, like measuring apnea or recording how to record apnea. But again, those are all placebo controlled, so there should not be any problem. The limitation of caffeine being stopped more frequently than placebo, we were surprised because most of the patients, the parents were not aware, obviously, of the difference. You saw only tachycardia in 4% only. So we were surprised that the parents stopped caffeine more in one group, stopped the medication more in the caffeine group than the placebo group.
Placebo group, yeah. Yeah, as you said, Dr. Carlo, it was interesting to see that difference, even though they were blinded to the study, which it's interesting to find that there was no cause and where it came from. And this is just an overview of the Oliphant et al. Study that was done in 2023, in which they showed that the 20 milligram per kilo per day was showed a 50% reduction in the intermittent hypoxemia in late preterm infants of 34 to 36 and 6 weeks.
So I can't resist commenting on this because I have, ever since it was published, great problems with this trial because it may send a completely wrong message to the clinical community. So we're looking here, as you say, at late preterm infants who are not really known for having a lot of problems with their respiratory control. And, you know, if they can still, you know, some of them, not everybody behaves the same. And even at the same gestational age, they don't all behave the same. And so there are clearly some who will still have apnea. And if they do, then you treat them, ruling out other causes of apnea, of course.
Yes.
But nobody, as far, you tell me if I'm wrong, I don't think either these authors or anybody else has shown in this population that this degree of intermittent hypoxemia that they saw disappear on caffeine even matters. Isn't that where is it even a clinical problem that they're trying to treat here? It's not a population that is that is a prime target for caffeine therapy, right? And every drug given unnecessarily becomes a poison. So I think the first thing to do is dig a little bit deeper into whether these hypoxemic events that they observed, you know, because hypoxemia isn't equal hypoxemia and it depends on the developmental stage of your brain and whatnot, is even an important problem. And then you can worry about how you might treat it. I think they started at the end, not at the beginning.
I understand, Dr. Schmidt, and I agree with you. I will dig in deeper to see if the study is even valid. I haven't, to be honest, completely gone through the study, but I do agree with your thoughts as well.
And, you know, to say, I think it wasn't even 200 patients. It wasn't.
No, it was 132.
So to then conclude after such a short-term treatment in so few patients that it is safe, it's also rather bold.
True.
Right?
Yeah.
Dr. Sreenivasan, perhaps in the interest of time, we can move along to your conclusion slide and then your slide about future directions.
Yes. So conclusion, we just talked about it. The caffeine helped in resolution of apnea, but then the achievement of full oral feeds delayed discharge more than the apnea resolution. And probably because of that, there was no difference in the primary outcome. And we kind of touched upon this before, that whether we could standardize oral feeding and stratify based on postmenstrual ages, which we said that the randomization would probably balance the groups. So it please take that point away. But otherwise, and make sure that these apnea events were actually properly documented. And in our unit, we do caffeine level evaluation. So I don't know if that's something that's done at every institution. So that was my only thought. Other thought was if the caffeine was actually in the therapeutic range.
I wish we knew what a therapeutic range is. There's actually public statements that you don't with the standard therapy, you don't need to do any levels. You can
Got it.
save the pokes and the lab costs. And in the caffeine trial, there were just over 2,000 patients. There wasn't a single caffeine level in those patients.
Okay. That's interesting. Would be good, like saving the babies of the pokes. So the future directions is the optimal dose and duration. And I agree with Dr. Schmidt. I think before publishing studies of higher doses of caffeine, it should be very valid and in the right subset of population. And what's the ideal timing to discontinue caffeine? The mechanisms and subgroups is which infants will benefit the most by the caffeine, by gestational age, physiological maturity, and feeding issues. And are the benefits driven by the respiratory stability versus the feeding endurance? I think Dr. Carlo touched upon it before, that initially we thought that the feeding was also associated with the respiratory. That's why initially it was oral/tube feeding. In addition, for the reason for using caffeine and looking at long-term outcomes such as neurodevelopmental outcomes beyond discharge, an impact on readmissions for apnea, bradycardia, or feeding issues. And regarding safety consideration, effects on growth and weight gain trajectories, and potential late adverse effects like arrhythmia, sleep disturbance, and health system or economic impact is the cost effectiveness of using caffeine in moderately preterm infants, and can it actually reduce safely the NICU stay and overall healthcare costs. And for broader applicability, should caffeine be routine for all moderately preterm infants, and the feasibility of outpatient or home caffeine monitoring. So these are just the future directions and the questions that still remain unanswered, and also there is a potential for rediscovering. That's it.
So, Dr. Schmidt, I had a question for you. So do you think the caffeine, sending babies caffeine on home would benefit for babies who are born at earlier gestation, who are more likely to have apneas and intermittent hypoxia, delaying their discharge?
Possibly. I'm retired from clinical service now for a few years actually, but I was active for many years, and I actually never discharged a baby home on caffeine. So that's just the practice that I personally used. But there is certainly the most immature babies on average are, of course, the ones who take the longest time to resolution. And there could well be a small group of them who manage everything else, who are fine in a crib and who grow on full oral feeds, but we've all seen kids like that. And with the gestational age falling ever further, even since I was practicing, this will become more of an issue. So I think those types of kids, but I would think you would take those who are in hospital then purely because they don't resolve their apnea. And that would be not huge numbers, but I was thinking actually, as I was thinking about the Journal Club this afternoon, obviously not even the network in the NRN, I was in the past also a member of that network. So I know, the one that Wally did this MoCHA trial with, even that network isn't big enough to do that type of trial because, these babies are not coming in huge numbers in the individual sites. But something like the, what's it called, Tiny Baby Collaborative could take on something like that. They all over the globe, right? And they're particularly interested in these extremely ultra preterm babies. So if they agree to do something like that, then we could actually find some answers for that particular question. Just a thought.
Yeah, very interesting thought.
And we saw that effect. The effect on apnea. Time to apnea free was improved by about 3 days.
Absolutely.
So I think it may be possible that if we take babies on full PO feedings, then that may be a benefit. But that was not the intention of the group, because we wanted to do it very early and see it would have a dramatic impact on oral feedings also.
Well, you showed that it didn't. So now the next step needs to be taken, right?
That's right.
So,
yep. And we're already designing the study. We have a study designed already to test it. Yep.
Okay.
That's good. So I think we're almost at time. So Dr. Carlo, to start with you, any final comments for all the trainees who are in the audience today about this trial?
I think a general comment is that we need to get high level of evidence to support our practices. And the practice of going home on caffeine, now, at least in this population, has been shown to not be effective. Whether there's a subpopulation of patients that may be beneficial, that's something else. But in general, that we should try to practice evidence-based medicine with the highest level of evidence possible. If it's not available, work towards getting that evidence.
Yeah. And I think the audience shares the same thing with us too. Most, as Dr. Schmidt pointed out, I think majority still use 10 mg per kg as their maximum caffeine dose, with few at 20. And very occasionally some units will discharge on caffeine, but most of them do agree that we still need more data, and it's probably not, based on this results, not clear yet to send babies home on caffeine. Until we find that right population, maybe from the Tiny Baby Collaborative, we can find those tiny babies to go forward. Dr. Schmidt, any final concluding statement for us before we wrap up this session?
No, I want to thank all of you for this session, and I couldn't agree more with Wally that we need to always ask what's the evidence, and I am also a little concerned. Sometimes you actually have to go back to the original paper. You can't get all your information from social media summaries. And I'm getting a little, I mean, you know, we're all very busy, and you guys are particularly busy, but, you know, I'm not on social media, but I monitor some of what goes on there, and it's not always correct. the way the data are represented there. So that would be has nothing to do with MoCHA, but a much more generic comment from a person with a lot of gray hair.
I think, and one thing I can say, today we learned a lot about not just the trial, but how to evaluate a trial. Excellent presentation in that, Gayathri, and as always, amazing mentoring by Dr. Schmidt and Dr. Carlo. Thank you so much for joining us and spending time. Dr. Carlo, I hope we could have seen your grandkids trying to be a researcher, a clinician, and a great granddad at the same time, but hopefully some other time. Thank you so much, everyone.
I did. Yeah, thank you.
Bye-bye.
Bye-bye.
So much. Bye.